Hematuria and kidney diseases. We have the tumors of the kidney. They are 3% of adult malignancies. 90-95% of neoplasms arising from kidney tissue of origin is the proximal and distal renal tubular epithelium, but also from the pelvis. Have a lack of early warning signs, diverse clinical manifestations in a limited percentage of patients. Resistance to radiation and chemotherapy, infrequent but reproducible responses to immunotherapy, interferon alpha and IL-2. Targeted therapy has been developed in the recent years, anti-angiogenic factors, anti-VEGF receptor 2, and it has been observed that it can control the disease and prolong survival. Diagnosis is late. 30-40% of cases present with metastatic disease. The tumor grows at very large dimension without previous symptoms. The most frequent tumors are the renal cell tumors, but there are also other components, as you can read in the classifications, like clear cell renal cell carcinoma, multilocular clear cell renal cell carcinoma, papillary renal cell carcinoma, chromophobe renal cell carcinoma, carcinoma of the collecting ducts of Bellini, renal medullary carcinoma, XP11 translocation carcinomas, carcinoma associated with neuroblastoma, mucinous tubular and spindle cell carcinoma, renal cell carcinoma, papillary, etc. Renal cell carcinoma. It's 85% of renal cancers in adults, so it's the most frequent. Males are more affected than females in the 50 and 60 years. VHL gene is implicated in carcinogenesis of both familial and sporadic tumors. We have a spherical yellow-gray-white mass with necrosis and hemorrhage. Invasion of renal vein is common. Prognosis depends on size and extent of spread. 25% show metastasis at time of diagnosis. The classic triad, only present in very few cases, is hematuria, costovertebral pain in flank, and palpable mass. Systemic symptoms are polycythemia in 5% due to erythropoietin production, hypercalcemia, hypertension, hepatic dysfunction, feminization, masculinization, Cushing syndrome, eosinophilia amyloidosis. Clinical features are hematuria in 50% of cases, pain, mass, paraneoplastic syndrome, fever, polycythemia in 5-10% of cases due to erythropoietin production, hypercalcemia, hypertension, Cushing syndrome. We have metastasis to lungs and bone. Macroscopically, you should look at the invasion of the vein, recognize histologically if the capsule is infiltrated or not. This is relevant for staging and prognosis. Risk collagen and degenerative areas due to substitution by fibrotic tissue. Sometimes there is a multicystic lesion. A large part of tumor has undergone necrosis and substitution with a cyst. The regression of tumor is almost complete. Renal cell carcinomas, melanoma can regress completely due to hemorrhagic phenomena and immune response, but the metastatic potential remains the same. At histology, you can observe abnormal large sinusoidal vessel. This is the same vascularization that can be observed at imaging and can be diagnostic. High specificity. Some areas may show regression and only hyaline and connective tissue. One of the most important things is to evaluate the renal vein. The tumor sometimes grows inside the vein and extends within the vein, extending to the inferior vena cava. The second most frequent tumor is papillary carcinoma. It presents with papilla, limited clearing of the cytoplasm. Frequently there is a mixture of macrophages and gross morphology shows a brown tumor. The papilla morphology may be different, so we can distinguish in type 1 and type 2, which also relies on different molecular alterations. Third malignant tumor in adults is chromophobe carcinoma. There are some clear cells, but not due to accumulation of lipids, no VHL association. At gross morphology, it is usually brown. There is degeneration of cytoplasm with accumulation of vesicles and cytoplasm at peripheries condensed. It accounts for 5% of tumors and the prognosis is usually favorable. Clear cell carcinoma derives from the proximal tubule, papillary carcinoma derives from the distal tubule, and chromophobe carcinoma derives from distal tubule, ansa of Henle or collecting duct. Oncocytoma also derives from distal tubule cells. It is benign and can reach up to more than 10 centimeters. It is difficult to distinguish from imaging studies that it's an oncocytoma, although in some cases there are imaging features that can suggest it: central scar and high vascularization. It's composed of oncocytic cells, which are a sign of the degenerative phenomenon in the epithelium. Different tumors in different organs share this characteristic: thyroid, parathyroid, adrenal gland, pancreas. The oncocytic feature of a cell is due to accumulation of abnormal mitochondria with pink and granular cytoplasm. We have the Wilms tumors, which is the most common primary renal tumor of childhood, usually diagnosed between ages 2 and 5 years, and the fourth most common pediatric malignancy in the United States. It's less frequent than lymphoma, CNS tumors, neuroblastoma. It recapitulates the tissue that gives rise to renal parenchyma, so the undifferentiated renal blastema. It's very aggressive. In 5-10% of cases may involve both kidneys, either simultaneously synchronous or one after the other, metachronous. Generally a large, solitary, well-circumscribed mass that is soft, homogeneous with occasional foci or hemorrhage, cyst formation and necrosis. It can be associated to genetic malformations associated with distinct chromosomal loci. We have Beckwith-Wiedemann syndrome, which is characterized by an enlargement of body organs, organomegaly, macroglossia, hypertrophy, omphalocele, and abnormal large cells in adrenal cortex, so adrenal cytomegaly. The genetic locus that is involved in these patients is in chromosome 11 distal to WT1 locus, a tumor suppressor gene P57. WAGR syndrome then is characterized by aniridia, genital anomalies, and mental retardation. There is a 33% chance of developing Wilms tumors. The genetic alteration is a deletion of 11p13 tumor-associated gene WT1. We have then Dennis-Drash syndrome, where we have gonadal dysgenesis, male pseudohermaphroditism, and early onset renal failure. Patients are at much higher risk for Wilms tumors, more than 90%. There is a missense mutation of WT1 gene located at chromosome 11p13. Histology, it has a triphasic appearance. We have a blastemic component where we have tightly packed blue cells, stromal component with fibrocytic or spindle-shaped cells, and an epithelial component with abortive tubules. Prognosis is good. Excellent results are obtained with a combination of nephrectomy and chemotherapy in most cases. If survival is more than 2 years, the patient can be considered cured. Clinical presentation is with a mass. It crosses the midline. We have hematuria, intestinal obstruction. Prognosis is good, but therapy is very aggressive. Nephrectomy or chemo plus nephrectomy plus chemo according to the size of the tumor. Another type of tumor is relatively frequent is angiomyolipoma. Diagnosis can also be made at imaging, but sometimes it can't be resected. It's also called PCOM. It derives from periendothelial cells, and the sporadic cases may be associated to tuberous sclerosis, genetic alterations with propensity to develop different kinds of tumors in different regions of the body, brain, kidney, endocrine system. The most important mutations are in TSC1, TSC2, that are tumor suppressor genes involved in the mTOR pathway. As the name implies, fat cells, smooth muscle cells, and endothelial cells are involved. Kidney may be the site of metastasis, especially from lung cancer. Multiple lesions can be observed. Renal cell carcinoma grading stage. Grading follows the Fuhrman grading system 1 to 4. TNM, we have T1 less or equal than 7 centimeters. T1A less or equal than 4 centimeters, T1B more than 4 centimeters, but less or equal to 7 centimeters. T2 more than 2 centimeters confined to the kidney. T2A more than 7, between 7 and 10, and T2B more than 10. T3 renal vein invasion, adrenal gland infiltration, and perirenal fat. T3A, renal vein and perirenal fat. T3B, vena cava below diaphragm. T3C, vena cava above diaphragm. And T4, beyond the gyrota fascia and homolateral adrenal gland. And 1, we have a single node regional node, and then 2 more than one regional node. Staging 1 T1 and 0 M0, 2 T2 and 0 M0, 3 T3 and 0 M0, or T1 3 and 1 M0, 4 T4 and 0 and 0 1 M0, any T Tn2 M0, any T any N and M1. If regional lymph nodes are involved, it's a bad prognostic sign. Histology, we have grade 1, small nuclei, very regular or no nucleoli. Grade 2, large nuclei with small nucleolus. Grade 3, large nucleus, bigger nucleolus. Grade 4, anaplasia with sarcomatoid features, worse prognosis. Renal cell carcinoma risk factors are smoke, hypertension, anti-hypertensive drugs, obesity, familial history, hereditary syndromes like von Hippel-Lindau's disease, hereditary papillary renal carcinoma, Birtog-Dubé syndrome, HLRCC syndrome, HPT-JT syndrome. These syndromes are very interesting because they helped us to discover some of the most relevant genes in the development of these tumors. We have structural alteration of chromosome 3p, tumor suppressor like VHL, TSG, or oncogenes like MET. 4 hereditary syndromes associated are von Hippel-Lindau syndrome, hereditary papillary renal carcinoma, familial renal oncocytoma associated with Birtog-Dubé syndrome, and hereditary renal carcinoma. Renal cell carcinoma cells can grow very easily in culture. Karyotypes can be obtained easily and they are very informative. In clear cell renal cell carcinoma, there is a loss of the short arm of chromosome 3. In papillary renal cell carcinoma, there is a gain of chromosome 7. In chromophobe, there is a loss of different chromosomes. In oncocytoma, there are alterations in short arm of chromosome 1. Von Hippel-Lindau syndrome. It's autosomic dominant. Tumors are present in the kidney, pancreas, islet cell tumors, pancreatic cysts, adrenal gland, pheochromocytoma, CNS, hemangioblastoma in cerebellum, eye, retinal angioma, internal ear, endolymphatic sac tumor, and epididymis. Clinical characteristics of the renal cell carcinoma in VHL are young age, multiple clear cells. 45% of VHL patients that caused by renal cell carcinoma. There are different deletions and mutations of von Hippel-Lindau syndrome, causing different clinical and genetic variants. VHL is part of the E3 ligase complex. It works together with elongin B and C to induce ubiquitination and degradation of the HIF-1 alpha transcription factor at the basis of the hypoxic control. During hypoxia, the mechanism is permitting the upregulation of HIF, which is not degraded, and if HIF is not degraded, there is an accumulation of other factors and the induction of expression of VAGF, GLUT1, and TGF-alpha. In papillary renal cell carcinoma, the other gene involved is MET, a tyrosine kinase. It has a role in survival and proliferation of cells. In these tumors, there is an increased activation of MET and other alterations. MET is important because there are several drugs against it, like crizotinib, but also used for other tyrosine kinase, ALK and ROS, and this mutation is relevant in lung carcinogenesis and renal cell carcinoma. The pathogenetic mechanism at the basis of the sporadic lesion is the same of the hereditary lesions. The difference is that hereditary lesions appear at a younger age. This is a very important slide summarizing the distribution of the different types of renal cell carcinoma and the molecular associations which are relevant for therapy and prognosis. There are now drugs that increase survival like sunitinib, sorafenib, and pazopanib. So clear cell associated to von Hippel-Lindau disease, von Hippel-Lindau genes present in 75%, 85% of cases. Type 1 papillary and type 2 papillary are make 14% of cases. 14% of cases. Type 1 papillary is H. papillary, c-MET gene. Type 2 papillary, H. leiomyomatosis, and fumarate hydrogenase gene. Chromophobe oncocytoma associated to Bird-Hogg-Dubé syndrome and the Bird-Hogg-Dubé gene is present in 3–4% of cases. Multiple myeloma, also called plasmacytoma, it's a tumor composed of mature and immature plasma cells, more common in older patients. It presents with lytic bone lesions and circulating and urinary monoclonal immunoglobulins. Prognosis is severe and intense treatment is required. Can involve the kidney due to excessive production of immunoglobulins that accumulate and damage the glomeruli and the tubular interstitial components. As a consequence, there is overt renal insufficiency in 50% of cases. Factors contributing to renal damage are Benz-John proteinuria and cast nephropathy. Benz-John proteins are directly toxic to epithelial cells and combine with the urinary glycoprotein, tamorsal protein, under acidic conditions to form large tubular casts that obstruct the tubular lumina and also induce a characteristic inflammatory reaction around the casts. So cast nephropathy. We have amyloidosis, so accumulation of light chains with predisposition to form amyloid fibrils. We have light chain deposition disease, so light chains deposit in the glomerular basement membrane and mesangium, causing glomerulopathy, or in tubular basement membranes, which may cause tubular interstitial nephritis. Also, hypercalcemia and hyperuricemia are often present in these patients. At histology, you observe thyroidization of kidney, tubules are dilated and filled with pinkish material, which is the excess of immunoglobulin that agglomerated as casts in the tubular lumen. This causes retention and alters secretion, also associated with inflammatory cells, and the secretive function of the kidney is impaired. So the tubular interstitial changes are Benz-John tubular casts appear as pink amorphous masses, sometimes concentrically laminated, often with a fractured appearance, filling and distending the tubular lumens. Some of the casts are surrounded by multinucleate giant cells that are derived from mononuclear phagocytes. The adjacent interstitial tissue usually shows a non-specific inflammatory response and fibrosis. Acute tubular necrosis. Acute renal failure associated with dysfunction and necrosis of tubular epithelial cells. Classification: ischemic or toxic. Ischemic can be due to shock, sepsis, burn, transfusions, or odor. Toxic can be due to drugs, metals, poisons, solvents, or odor. You can have acute drug-induced interstitial nephritis, which is a well-recognized adverse reaction to a constantly increasing number of drugs. Most frequently occurs with synthetic penicillins like methicillin, ampicillin, other synthetic antibiotics like rifampin, diuretics like thiazides, NSAIDs, and miscellaneous drugs like allopurinol and cimetidine. Acute pyelonephritis, the causes are an ascending infection, so vesicoureteral reflux into the renal pelvis and papillae, due to E. coli, Proteus, and Enterobacter, hematogenous seeding due to septicemia or endocarditis, Staphylococcus and E. coli. Chronic pyelonephritis, it's a chronic tubular interstitial inflammation with renal scarring and an important cause of end-stage renal disease. There are two forms. We have a reflux-associated one, which is common congenital vesicoureteral reflux or intrarenal reflux. Non-obstructive one, where we have a posterior urethral valves, urethral calculi, or abnormalities. Also in this case, you can see the thyroidization of renal cells. Urinary tract tumors. Among the clinical symptoms that are relevant for diagnosis, hematuria is the most important. Urine cytology is the first test that can be performed. It has a low sensitivity, so it's difficult to diagnose low-grade tumors, while specificity is high. So in the presence of hematuria, you have to do a cystoscopy, and if some alterations are found, you need to perform a biopsy. The surgical specimens that can be analyzed come from a transurethral bladder resection or from cystectomy. Uroepithelial tumors more often come from the urinary bladder in 94% of cases, but also from the renal pelvis in 5% of cases, and from the ureter in 1% of cases. From what concerns prevalence, there are 50,000 new cases of urinary bladder carcinoma per year in the USA, and 15,000 new cases of renal cell carcinoma per year in the USA. Risk factors are smoking, analgesics like panacetin cyclophosphamide, occupational carcinogens like coal, asphalt, tar, petrochemicals and plastics, papillary necrosis, familial cancer syndrome, where we have hereditary non-polyposis colorectal cancer linked to. 90% of urothelial tumors come from transitional cells, 9% from squamous cells, and there is association with chronic schistosome infection, and less than 1% from other cells, giving rise to adenocarcinomas, sarcoma, differentiated tumors, and benign mesodermal tumors. These tumors can be classified as papillary and non-papillary, invasive and non-invasive. 50% of papillary tumors are invasive, most of the non-papillary and invasive are malignant. Transitional cell tumors. Pathologic classification range. We have well-differentiated papilloma, grade 1, which is a very rare lesion. Malignancy, most with different degrees of potential evolution. You have to remember that these tumors may be frequently multiple, so the entire urothelium may be involved, and the patient has to be followed lifelong. Here is a summary. There are non-invasive and invasive lesions with increasing grade of malignancy. PUNLMP, papillary urothelial neoplasm of low malignant potential, NILGC, non-invasive papillary carcinoma of low grade, and NIHGC, non-invasive papillary carcinoma of high grade, are non-invasive, low-grade malignancy. They might recur, but are non-invasive because they are genetically stable. Then, and NIHGC, non-invasive papillary carcinoma of high grade, and CIS, carcinoma in situ, are genetically unstable and are invasive. So we have two types of NIHCG. As you can see, there are two NIHCG, and this is a problem because there is no tool that helps us in distinguishing the NIHCG that will progress from the NIHCG that will not progress. We cannot recognize CIS because it's a non-papillary flat lesion and it must be treated accordingly. Standard therapy for CIS is the instillation in bladder of BCG. The majority of superficial urothelial carcinoma are non-invasive papillary, not invading the underlying tissue. 70% of these superficial papillary tumors will recur over a prolonged clinical course, causing significant morbidity. Histology, you see hyperplastic urothelium with very few atypia and mitosis. When we do cytology, it's very difficult to distinguish those cells from normal cells. As already said, cytology is not a sensitive test for low-grade lesions. For 8% of these papillary lesions will eventually progress to invasive carcinomas. These tumors are pathologically graded as either low malignant potential, low grade, or high grade. High grade tumors have a higher risk of progression. CIS is a flat urothelial carcinoma in situ. We have a pathologic stage PTs. It's highly aggressive and progresses more rapidly than the papillary tumor. There is also an intermediate category that is the superficial invasive urothelial carcinoma, where the tumors invade only superficially into the connective tissue, lamina propria of the bladder. Pathologic stage PT1. These tumors recur 80% of the time and eventually invade the detrusor muscle in 30% of cases. They are treated with local resection and cystectomy. Approximately 30% of urothelial carcinomas invade the detrusor muscle. Pathologic stages PT2 and PT4 at presentation and are called muscle invasive bladder cancer. These cancers are highly aggressive and are treated with cystectomy. After bladder cancer invades the muscular layers of the bladder wall, it may spread by way of the lymph and blood systems to our invaded bone, liver, and lungs. Malakoplakia is a non-neoplastic lesion observed in the bladder, but also in lymph nodes, intestines, and kidneys. It has a presentation very similar to that of tumors, but it's a granulomatous response to E. coli infection. There are macrophages that contain cytoplasmic inclusion bodies called Michaelis-Guttman bodies. When it's confined, prognosis is generally good. These patients have to be treated with very long antibiotic therapy, but when the lesions are diffused or in immunosuppressed patients, prognosis may be worse, even if it's not a malignant lesion.